Naruvi Hospitals, promoted by the Sanko Foundation, is the brainchild of the founder-chairman Dr. G.V. Sampath. Belonging to Vellore, the medical hub of India, Dr. Sampath's vision to create a medical destination for the people of Vellore in particular and others from India at large and also overseas resulted in the establishment of a hospital here, a real crown jewel in the field of healthcare. Large numbers of people belonging to Vellore and the surrounding districts have been known to travel to Chennai and Bengaluru, both nearly 200 kilometers away from Vellore, seeking medical care due to the dearth of facilities and the hardships faced by the locals to access available services. As per the vision of the chairman, the best in healthcare, both in terms of medical and nursing professionals as well as sophistication, were infused into the institution, making sure that patient affordability was addressed at all times. Less than a month after Naruvi Hospitals opened its doors to the public, the second wave of COVID loomed large as life. We took on the challenge and quickly rose to the occasion, catering to the local population and some from outstation as well, adding close to 40 critical care beds and over 200 ward beds to the COVID care pool. Much as it was hard for a 1-month-old hospital to handle such large volumes of very sick patients, Naruvi Hospitals was able to contribute significantly in our country's efforts to save people from the disastrous end that COVID was driving people to. Naruvi Hospitals is positioned as a high-end tertiary care center. Our focus on ethics, transparency, patient satisfaction, and an academic outlook in everything we do ensures that doctors, nurses, and others in the care team are performing at their conscientious best to not only treat patients' ailments, but also to make them happy overall when they leave our hospital. We have tied up with the Henry Ford Health System, HFHS, based out of Michigan State in the United States of America. HFHS is one of the old and leading healthcare delivery systems in Midwestern America. The main aim of this tie-up is to have constant transfer of knowledge and to get access to the time-tested practices they have been following for decades, which ultimately translated to patient care. Naruvi Hospitals is a completely paperless and filmless hospital. The Naruvi philosophy of care is embodied by our motto, Fragrance of Care. The doctors in Naruvi are largely trained in the best of medical institutes in India and come with years of rich experience in their fields of expertise. With the philosophy and its pallbearers, the medical and nursing professionals, the high-end equipment, and the building infrastructure complete the holistic picture of Fragrance of Care. The hospital is 475 bedded with a 25% critical care bed count. Naruvi Hospitals boasts of an over 5 lakh square foot building spanning 14 levels. The building is completely air conditioned, conforming to ASHRAE standards with zone-specific air conditioning to reduce cross-infection between different care areas. Our laundry is 100% barrier washed. We have a top-of-the-line sterilization department with machines with 95% water-saving machines, saving up to 300 liters of water every running hour. We have all the major medical and surgical specialties. There are 16 modular operation theatres with laminar airflow. All the equipment in the ICUs and OTs are pendant mount to avoid clutter on the floor. All the departments are equipped to the most modern standards with the best and latest equipment so as to be able to provide the best end-to-end treatment to our patients. State-of-the-art cardiac cath labs, the latest robotic hybrid OT, ECMO, interventional pulmonology, high-end orthopedics, general and bariatric surgery, epilepsy monitoring unit with robot-guided epilepsy surgery, neuro monitoring, navigation, the latest lithotripter, urology laser are just some of the arrows in our quiver. Our primary focus, though being the local Vellore people and Indians at large, we are working towards attracting overseas patients as well. We have started an office in North Sudan in Khartoum. We're in the process of tying up with the governments of Oman and Seychelles as well. In all, Naruvi Hospitals is more than a hospital. It is an experience. Naruvi Hospitals.
A happy Sunday morning and a warm welcome to all today who have joined today's webinar under the Hindu Wellness Series presented by Naruvi Hospitals, Vellore. We are going to discuss an important topic today, cancer, its early detection and prevention. Cancer is the largest non-communicable threat that ruins our physical and mental well-being. It is important to talk about the dreaded disease because that is the best possible way, perhaps, to conquer fear and anxiety and understand its early symptoms to try and prevent it if possible. A team of oncologists from Naruvi hospitals are on the panel today to talk on the subject and create awareness. I would first invite Dr. T. Alvin Yabesh, Senior Consultant in Medical Oncology, currently practicing in Vellore. After completing his MBBS and MD in general medicine, after completing his MBBS and MD in general medicine from Kilpauk Medical College, Chennai, he did his super specialty training in medical oncology in Apollo Cancer Center in Chennai, where he worked as an associate consultant in Precision Oncology Hematology Group for 2 years. His special interest is in molecular and precision oncology. And he will now give a presentation on global cancer burden and modifiable risk factors. Welcome, Dr. Alvin.
Thank you for the introduction. Let me share my slides. Hope my slides are visible.
Yes, sir.
So, very good morning to one and all. I would like to sincerely thank Naruvi Hospitals and The Hindu for organizing this webinar to spread health education among the public. The topic for today's discussion is cancer, prevention and early detection. Basically, what is cancer? It is the uncontrolled multiplication of our own body's cells. God has created our body in such a way that our cells die and multiply in a balanced way. So if this balance is lost or it is tilted towards the multiplication, it results in cancer. So I would like to focus on two important topics today. One is cancer burden across the globe, and the other one is the modifiable risk factors for cancer. In 2022, a world has recorded almost 2 crores of cancer cases, and there has been almost 97 lakhs of cancer deaths, and there are 5 crores of patients living with cancer. Among males, lung cancer tops the list, followed by prostate, colorectal, stomach, and liver cancer. Whereas in females, breast cancer tops the list, followed by lung, colorectal, cervix, and thyroid. What about in India? In 2019, our country has recorded almost 9.3 lakhs of cancer deaths, which is the second highest in Asia. In 2022, our country has recorded almost 14 lakhs of new cancer cases, and there are 9 lakhs of cancer deaths and 32 lakhs of patients living with cancer. In our country, oral cavity and lip cancers top the list, followed by lung, esophagus, colorectal, and stomach. Whereas in females, breast cancer tops the list, followed by cervix, ovary, lip, oral cavity, and colorectal cancers. When you look into the country, by and large, into the different states, we see that Assam, Kerala, Karnataka, and Haryana are the highest incidence recording states for cancer. There are many reasons to it. The most common reason is the high risk behavior that are prevalent in these states. For example, pan chewing is more common in Assam. The other reason is some states, they have a very good cancer reporting system. This is the estimated cancer burden in the future. In 2040, we expect almost 19 lakhs of cancer cases to be recorded in our country. And these are the cancers. In the last few decades, we see that they are increasing in trend. Breast cancer, lip and oral cavity, and colorectal cancer. Now, why do we have to look into these statistics? By these statistics, we understand that we are living in an era of non-communicable disease, of which cancer is the most important threat. So the questions that arise in our mind are, How to overcome this threat? Is cancer a preventable disease? Can we do anything to prevent cancer and declare a cancer-free world? Yes, 30 to 50% of the times cancers are preventable because they are caused by modifiable risk factors, and the remaining challenge can be effectively managed by early diagnosis and effective treatment. So, what are these modifiable risk factors? These are behaviors or exposures that increase the risk of acquiring cancer. They are modifiable because they can be changed and they can be stopped. The first important risk factor is tobacco. We are all aware that tobacco is available in different types of products, which can be either a smoke producing or a smokeless. Cigarettes, BD, e-cigarettes, hookah, pipes, they are the smoke producing tobacco products. Gutka, snuff, and chewing tobacco are the smokeless products. All are harmful because when one starts to initiate smoking, he gets addicted to the habit because of the substance called nicotine, which is a pleasure giving chemical. As such, nicotine is not carcinogenic. The tobacco smoke, what one inhales, has got thousands of compounds, and 60 are known to be carcinogenic. Carcinogenic is a chemical that can induce cancer in our body. The notable chemicals that are found in the tobacco smoke are the polycyclic aromatic hydrocarbons, nitrosoamines, aromatic amines, acetaldehyde, and isoprene. These are known to be highly carcinogenic. So when one inhales these carcinogens, they tend to cause some changes in the DNA called DNA adducts, and they cause mutation in some of the important genes that control our growth of a body. And this mutation can cause loss of normal growth control, leading on to cancer. Tobacco use can cause cancer throughout the body, starting from mouth, throat, esophagus, lung, liver, stomach, pancreas, bladder, cervix, kidney, etc. In one country, in one research, they have found that almost 80% of the lung cancers, 70% of the larynx cancers, and 50% of the esophageal cancers are caused by these tobacco products. So the decision to quit smoking should not be delayed because even after stopping the habit, it takes almost 5 years to halve the risk of acquiring oral cancer. It takes 10 years to reduce the risk of acquiring bladder and esophageal cancer. And it takes almost 15 years to halve the risk of acquiring lung cancer. So the decision to quit smoking should be prompt and imminent. Sometimes we have some questions in our mind. Despite smoking heavily, why some get cancers and others don't? Because when one inhales these carcinogenic metabolites, they will be activated into a more active chemical to cause cancer. At the same time, they can be detoxified and nullified by the enzymes that are present in our body. This potential to activate or detoxify, it varies from individual to individual. If an individual has got a higher activation capacity and lesser nullification capacity, that individual has got a higher cancer susceptibility. Hence, the higher the risk of acquiring cancer when someone starts smoking less than 18 years and smokes for more than 20 years. The other important fact is the passive smoking. Even if one doesn't smoke, but standing near to a smoking individual, he is at risk of inhaling the exhaled smoke, which can also contain these carcinogenic substances. And they are also known to cause some of the cancers like breast and lung cancer. So how to quit smoking? The individual has to decide. If he is able to quit smoking on his own, well and good. If not, there are de-addiction centers available throughout. What do? They advise on the harmful effects of smoking. They assess the individual willingness to quit. If he is very much willing, they assist and arrange behavioral programs to help to quit smoking habit. And even if it is not possible, there are drugs that are available to cause de-addiction. The next important risk factor is the alcohol. We are all aware that alcohol is a toxic, psychoactive, and dependence producing substance, and it has been classified as Group 1 carcinogen by International Agency of Research on Cancer. Alcohol is known to cause cancers of the mouth, voice box, breast, liver, foot pipe, colon, and throat. How it causes cancer? Alcohol and ethanol are one and the same. When it is entering in our body, it gets converted into acetaldehyde and free radicals. and these can cause some of the DNA changes in the body and promotes cancer. Alcohol has got a strong link with some of the cancers, namely oral cavity, liver, colorectal, and breast cancer. Is there a safe alcoholic beverage? No. Red wine, white wine, beer, alcohol, all can cause cancer. Is there a safe level of alcohol to drink? WHO states that there is no threshold at which the carcinogenic effects of alcohol get switched on. So it doesn't matter how much you drink, the risk to the drinker's health starts from the first drop of any alcoholic beverage. The only thing that we can say for sure is the more you drink, the more the harmful it is. The third risk factor is the unhealthy diet. What is the unhealthy diet that we are talking about? It is the ultra processed food. These are found in the fast food restaurants and sold in supermarkets. They are all industrially manufactured. They have some added ingredients and additives like modified starch and hydrogenated oils. They have got a long shelf life and they are ready to eat. For example, or the soft drinks, sweet or savory packaged snacks, processed meat, frozen or shelf-stable dishes. How this ultra-processed food increase the risk of cancer? By three important ways. One is the food packaging chemical contaminants, which contains this diethyl hexyl phthalate and bisphenol A. This has got a carcinogenic property. And there are preservatives that are used to preserve poultry and meat, which contain sodium nitrite, which can also yield carcinogenic nitrosamines. And there are cosmetic additives like flavors and emulsifiers. They causes metabolic alteration and gut inflammation. So these ultra-processed food are implicated in increasing the risk of following cancers, namely pancreatic cancer, colorectal cancer, and breast cancer. The bottom line is, though it is not necessary to completely avoid them, but we have to limit the consumption of the ultra-processed food and have to give preference to fresh and minimally processed food. The fourth risk factor is the obesity. Obesity, as we all are aware, it is characterized by excess body fat, but medically we define it by body mass index. That is the weight in kgs divided by height in meters. If that is more than 30, we call the individual to be obese. There is another term called abdominal obesity. This is measured in such a way that we can take an inch tape and measure our abdominal circumference at the level of our belly button, that is the umbilicus. And we also can measure the level of the abdominal circumference at the level of hips. When we divide the waist circumference by hip circumference, if it is more than 0.9 in men and more than 0.85 in women, we call those individual as abdominally obese. How obesity is linked to cancer. An obese individual tend to have more adipose tissue. Adipose tissue is nothing but the fat cells. Excess of fat cell can result in immune dysfunction. Our immunity is very important in protecting our body against tumor. So when this immune dysfunction happens, there is a chance of acquiring cancer. And excess fat cells can reduce the adipokines. Those are the substances that are found in our body, which are protective against cancer. These fat cells also can increase the sex hormones, which can be harmful. And these fat cells, excess fat cells, can cause insulin resistance, thereby more growth factors can be produced in our body, resulting in cancer. And excess adipose tissue also causes some inflammation of our body, resulting in cancer. Obesity is associated with various cancers, starting from thyroid, breast, liver, gallbladder, stomach, pancreas, uterus, ovaries. Almost 4 to 8% of all cancers are attributed to obesity. And excess body fat leads to 17% increased risk of cancer-specific death rates. So one has to aim in reducing the weight if he or she is obese. The simple thing that we can do at our home is doing a moderate physical activity, almost 30 minutes a day for 5 times a week. Simply like walking, cycling, or gardening, swimming, and doing a household chores, and maintaining a healthy diet rich in fresh fruits, vegetables, beans, and whole grains. The bottom line is walk more and sit less. Even among cancer survivors, we encourage them to lose weight and maintain a normal weight because an obese individual has got a high risk of cancer recurrence. So for all cancer survivors, we encourage them to do exercise and maintain a proper diet. If the exercise and diet is not helping them, then comes the behavioral intervention like weight reduction surgeries and drugs. Not for all patients, especially if the patient has got some another major comorbid illness. And the next risk factor is the infection. There are many infections that are linked with cancer, but we are worried about some of the major infections like hepatitis B, hepatitis C, HPV, and H. pylori, because 90% of the infection-related cancers are caused by these. Hepatitis B and C are known to cause hepatocellular carcinoma, and HPV, that is the human papilloma virus, is known to cause cervix, vulval, anal, and oral cancers, and H. pylori is known to cause gastric cancer and lymphoma. So how to stay away from these infections? Avoid sexual promiscuity to avoid HPV infection. And there are strict vaccination schedules available to protect against the human papilloma virus. Our next speaker will be elaborating on this. And maintain a proper hygienic diet to protect against the H. pylori infection. And even if the patient has got HPV or HCV or H. pylori infection, there are prompt treatment available, and strict adherence to the treatment help eradicating these infections and reduce the risk of acquiring cancer. So to summarize, move your body, eat well, maintain a healthy weight, do not drink, do not smoke, practice sun safety, that is, expose yourself to early morning sunlight, which helps increase the vitamin D in our body, which is shown to be protective against some of the cancers. Again, I would like to reiterate the fact that though all cancers are not preventable, almost 30 to 50% of them are preventable because they are caused by these modifiable risk factors, and the remaining challenge can be effectively managed by early diagnosis and effective treatment. Thank you.
Thank you, Dr. Alvin, for the detailed presentation. Before I request the next speaker, I would also request our audience to send in their questions. The chat box, the Q&A box is open, so please start sending your questions. Our next speaker is Dr. G. Sindhu, presently working as junior consultant in Department of Medical Oncology at Naruvi Hospitals, Vellore. She did her MBBS from Osmania Medical College, Hyderabad, MD in General Medicine from Sri Venkateshwara Institute of Medical Sciences, and DM Medical Oncology from Nizam's Institute of Medical Sciences, Hyderabad. After a year's stint as assistant professor in general medicine at the Sri Venkateshwara Institute of Medical Sciences in Tirupati, she joined the Naruvi hospitals. Her talk is on screening methods for different types of cancers in average risk individuals. Over to you, Dr. Sindhu.
Good morning, everyone. So I would, at the outset, I would like to thank Naruvi Hospitals and the Hindu paper for creating this initiative to spread awareness among the people. So I would be discussing about the cancer screening methods which we have, which would help detect cancer early. So cancer screening tests detect pre-cancer or early stage cancer in asymptomatic individuals so that timely diagnosis and early treatment can be offered. With this treatment can lead to better outcomes for many people. The aim of a cancer screening program is either to reduce mortality and morbidity in a population by early detection and early treatment, for example, a breast cancer screening, or it also helps to reduce the incidence of cancer by identifying and treating its precursors such as cervical and colorectal screening. So some cancer screening programs are targeted to people who are at high risk for particular cancer because of the behavioral or genetic predisposition. This is known as targeted screening, such as lung cancer screening targeting people who have a high use of tobacco. So what is this cancer screening? It is to perform a test or an examination on an asymptomatic individual. The cancer screening aims to detect cancer before the symptoms appear. Now, this may involve blood tests, stool tests, or imaging techniques. And usually these tests are not confirmatory for cancer, but indicate that a cancer may be present. The screening recommendations depend on the individual's risk, with high-risk people receiving earlier and more frequent screening than the low-risk people. So like every diagnostic tool, screening tests are also associated with benefits as well as harms. So the benefits with the screening test is that you can detect cancer early, so the severity and the morbidity associated with the disease will be less. You can plan a less invasive treatment when it is detected at an earlier stage, and it is also known to reduce incidence in some cancers and also reduced mortality. On the other hand, there are many harms which are associated with cancer screening. Like few cancers can be diagnosed in the indolent stage which do not need any treatment, so that is known as overdiagnosis. Or some cancers can be treated unnecessarily where they do not need treatment, that is known as overtreatment. There can be false positives in these screening tests which can cause anxiety and psychological effects in the individuals, and also false negatives where we can miss an important cancer. So screening is normally useful, not normally useful for rare cancers, and screening recommendations majorly focus on treatable cancers found in the populations. Therefore, we have screening recommendations for the following cancers, which I would be discussing in the following slides. So first, coming to the most common cancer worldwide and in India, that is the breast cancer. So there are three known modalities for the breast cancer screening. One is breast self-examination, clinical breast examination, and imaging techniques like mammography and breast MRI. There are no studies which show that this breast self-examination and clinical breast examination have a mortality benefit, but the imaging techniques do have a mortality benefit. So clinical breast examination is a physical exam which is done by a clinician to check for the breast cancer by looking for lumps or other changes or abnormalities in the breast tissue. We usually do a visual check for any asymmetry in the both breasts or any visual changes like skin ulcerations, nodules, or any edema of the skin. And then we feel for the abnormalities by applying a firm pressure to look for any lumps or swellings. And also we check for any lymph nodes and if the nipples have any discharge or if they are abnormally positioned. So the next screening tool is a mammography, which is an X-ray image of the breast that can help detect breast cancer and other breast diseases. The patient's breast is placed on a flat surface and compressed with a paddle, and an X-ray machine produces a small burst of X-rays that pass through the breast. The X-rays are then recorded on a photographic film plate or a solid-state detector. So the radiologist then examines these mammograms for the area of unusual configuration, that is high density or tiny calcium deposits. So there are many prospective randomized studies which have proven that this mammography has reduced the relative risk of breast cancer death by almost 10 to 25%. So these mammographies are reported with a breast imaging reporting and data system. There are 6 criteria categories, and the 0 is unclear, whereas 1 is negative, that is the breast tissue is completely normal. 2 is benign lesion is found. 3 is a probable benign lesion, but generally for up to category 3, for the category 3, we just keep the patient on follow-up. For 4, we suspect a cancer, and a category 5 is highly suggestive of cancer, and we generally go ahead with a biopsy of the lesion. Whereas category 6 is a biopsy confirmed lesion on a mammogram. Dense breast tissues can make it harder to see small tumors, which also appear white. So the dense breast as well as the tumor appear white on a mammogram. And in these conditions, we generally prefer a breast MRI. Generally, younger premenopausal women tend to have a denser breast. Also, women with dense breasts have a higher risk of developing breast cancer, and the risk increases with denser breasts. So annual MRI is used for screening women with these elevated breast cancer risk due to the congenital mutations or the syndromes, like the genetic syndromes or the mutations like the BRCA mutations, Lee-Fromeny syndrome, Cowden's disease, or a very strong family history. And here, this annual MRI should be started at the age of 25 years. Also, annual MRI is recommended in patients who had a prior chest radiation for some other disease like a lymphoma between the age of 10 to 30 years. MRI is more sensitive, but it is less specific than a mammography, which can lead to a high false positive rate. Hence, it is limited to those women who are young and need a early screening of breast cancer. Breast ultrasound has never been used as a screening tool for breast cancer. However, ultrasound is used to diagnose a breast mass which is identified by either palpation or mammography. So, to reduce these inconveniences or the harms of screening, we should identify women who are at greater risk of breast cancer and refocus our screening efforts on those most likely to benefit. So the risk factors for breast cancer include extremely dense breasts on mammograph or a first degree relative with breast cancer are each associated with at least twofold increase in breast cancer risk. Also, prior benign breast biopsy, second degree relatives with breast cancer, and heterogeneous dense breast are also associated with an increased risk. And current OCP use, oral contraceptive use, nulliparity older than the age of 30 years, or age at first birth of 30 years or older is also associated with a 1 to 1.5 fold increase in the risk. So for the other high risk features are those who are known or likely carriers of a BRCA genetic mutation, have other high risk genetic syndromes like Cowden-Leaf-Romany, all these genetic syndromes. Then they have been treated with radiation, as already mentioned, and also have a approximate risk of 20 to 25%, which is estimated by a breast cancer risk estimation model. So for all these patients, there is a recommendation of doing either a mammography or an MRI annually starting at the age of 30 years. So the women who do not fall in this high risk criteria are the women at average risk, and they should undergo regular screening mammography, which starts at the age of 45 years. So women from 45 to 54 years should be screened annually, and women should also have the opportunity, if they want, they can begin annual screening between the age of 40 to 44 years as well. And above 55 years, it can be changed to a biennial screening. And if they want to, they can still continue an annual screening. And women should continue screening mammography as long as their overall health is good and they have a life expectancy of 10 years. And these American screening recommendations do not recommend clinical breast examination or breast self-examination as a screening tool. However, the National Comprehensive Cancer Network recommends the clinical breast examination for a woman with average risk from 25 to 40 years every 1 to 3 years, along with breast cancer awareness. For about 40 years, annual clinical breast examination is recommended. And for about 35 years with a high risk, every 6 to 12 months with a screening clinical breast examination along with screening mammography is recommended. So coming to the next most important cancer, which is very common in India, is cervical cancer. So the cervical screening modalities are the pap smear, the human papilloma virus DNA testing, and visual inspection by acetic acid. So pap smear testing is just a procedure where a small brush is used to gently remove the cells from the surface of the cervix and the area around it. And these cells are then checked under a microscope for cervical cancer or cell changes that may lead to cervical cancer. A HPV DNA test, on the other hand, is a laboratory test that involves collecting a cell sample in a similar way like the pap smear from the cervix with a brush or a swab. And then this sample is sent to a lab for being analyzed by the computer to test for this human papilloma virus DNA. Now, this HPV screening can be used along with the pap smear, that is a cytology screening, which is known as co-testing, or it can be done in a response to an abnormal pap smear, that is called as reflexive testing. That is, if a woman has a positive pap smear, then the women can undergo a HPV testing. And if that is positive, it can be further followed by a biopsy. In low resource countries where we have limited access to these pap smears and HPV DNA testing, there's another beautiful screening tool, that is a visual inspection of the cervix, which is a simple and an inexpensive method of screening that is now recognized as having the potential to save thousands of lives per year in countries like ours, where cytology and this HPV are not readily available. Visual inspection with acetic acid is naked eye examination of a uterine cervix after the application of 5% acetic acid, and the results are interpreted after 1 minute then and there. If an abnormal staining is detected, a biopsy can be performed from that area and sent for histopathological examination. There's a study from Tamil Nadu which showed that this visual inspection under acetic acid screening is an effective method to prevent cervical cancer in developing countries. So the American Cancer Society recommendations for cervical cancer screening should begin at the age of 21 years of age, Women aged 21 to 29 years should receive cytology screening, that is pap smear, with either conventional cervical cytology smears or liquid-based cytology every 3 years. Now, HPV testing should not be performed in this age group. For women aged 30 to 65 years, the preferred approach is to be screened every 5 years with HPV testing and cytology. It is also acceptable to continue this pap smear screening every 3 years. And women should discontinue screening after the age of 65 years if they had 3 consecutive negative pap smears or 2 consecutive negative HPV DNA test results within the 10-year period before ceasing the screening. With the most recent test should be done within the last 5 years. And women who have undergone a total hysterectomy for non-cancerous conditions do not need to undergo cervical cancer screening. Women, regardless of age, should not be screened annually by any screening method, and who have received HPV vaccination also should be screened according to the mentioned schedule. So this cervical cancer, though deadly, is highly preventable. All HPV vaccines have been found to be highly efficacious with an efficacy of 93 to 100% for the prevention of HPV vaccine type related persistent infection, cervical intraepithelial neoplasia, and adenocarcinoma in situ. And this HPV vaccine protects not only from a cervical cancer, but also for majority of the oral, penile, vulval, vaginal, and anal cancers as well. So there are 2 types of HPV vaccines which are available. One is a bivalent vaccine, which is the Cervarix vaccine, which protects against the serotypes 16 and 18. Whereas a quadrivalent vaccine called Gardasil is also available, which protects against the serotypes 6, 11, 16, and 18, hence protecting against genital warts, that is benign conditions as well, along with the cancerous conditions. So this is Sarvavac, which is prepared by the Serum Institute of India. It's the India's first indigenous HPV vaccine, which comes at a lower cost and is equally efficacious, and is a quadrivalent vaccine. And the newer vaccine, which has been introduced recently into the Indian market, is Gardasil 9, which protects against 9 serotypes of the human papilloma virus. Hence, its efficacy is almost 100%. HPV vaccine is recommended for both boys and girls with routine vaccination, which start at the age of 9. Vaccination is recommended for everyone through age 26 years. And it is not recommended for everyone older than 26 years. Some adults from 27 to 45 years might decide to get HPV vaccine based on the discussion with their clinician if they did not adequately get vaccinated when they were younger. HPV vaccination of people in this age range provide less benefit for several reasons, including that more people in this age have already been exposed to this human papilloma virus. The schedule of this HPV vaccine, whether it is a Cervarix or a Gardasil, is from 9 to 14 years of age. There are 2 doses are sufficient. First is at the first visit, and the second dose is 6 months later. Whereas from 15 years to 45 years or 15 years or older, you will have to take 3 doses. The first dose at the first visit, second dose 1 month after the first visit, and the third dose 6 months after the first visit. And these vaccines are very safe, and only the most common adverse reaction which is reported while taking this HPV vaccine is just a local site reaction and mild pain. Coming to the third most important cancer.
Could I interrupt you, Dr. Sindhu, because we are almost coming to the end of the program and your presentation, I think. How long is it? We have another speaker left.
Oh, okay. Should I conclude it?
Yeah, maybe we could take, because we also need to take a few questions. We have already started receiving questions.
Yeah, sure, no problem.
Yeah, so if you could just wind it up.
So to summarize, the screening is for a cancer is a form of secondary prevention. So detecting these cancers early through screening can significantly improve outcomes by delaying or halting disease progression, increasing the cure rates, and significantly reducing morbidity and mortality. However, it is crucial to remember that cancer screening may not be beneficial for every patient, and this is why it's empowering to discuss your eligibility, potential benefits, and also the risks associated with your specialist before deciding to undergo screening tests. Now, this discussion puts you in control of your healthcare decisions. So the best protection is early detection. Thank you.
Thank you, Dr. Sindhu. We'll now move on to our final speaker for the day, Dr. Rahul Krishnan, who did his MBBS from IRT Perundurai Medical College, Erode, and his master's in general surgery from University College of Medical Sciences, New Delhi. He completed his MCH in surgical oncology from Kidwai Memorial Institute of Oncology, Bangalore. With 5 years of experience as a general surgeon and 4 years in the field of surgical oncology, Dr. Rahul now works as consultant surgical oncologist at Naruvi Hospitals, Vellore. His presentation is on hereditary cancers and prevention. Welcome, Dr. Rahul.
Yeah, I hope everyone is able to see and hear me. Yeah.
Yes, yes.
Yeah. So good morning to all. I want to thank the Hindu and Naruvi hospitals for the opportunity given to us. And today I'm here to talk about hereditary cancers and preventions. In simple terms, hereditary cancers are cancers which have the potential to run in your family and which and potential to be passed on to the next generation or the previous generation before you. So today I've picked up some common cancers among them for which there are established guidelines and protocols on how to prevent and treat. So my aim here today is to educate very superficially about how to suspect, evaluate, and prevent hereditary cancers. So going into the presentation now. Yeah. So there are some key elements to evaluate a family, a cancer running in your family. So the first one would be a family history, which should be taken thoroughly and updated periodically whenever you visit the hospital or the oncologist. So key components should always include information about the first degree relatives like your sibling, your parent, or your child. Those and about second degree relatives like grandparents, aunts, uncles, grandchildren, niece, nephews, and half siblings. And we have to be sure which side of your family the disease is running or not. So maternal and paternal sides have to be evaluated. And some ancestries like Ashkenazi Jew patients have increased risk of breast and other cancers. So for each case in the family, establish age at the cancer diagnosis and type of the primary cancer which was diagnosed in case there is a history of cancer in your family. So before going into depth, I'll just touch upon basis of genetics. It is the Knudsen's-2 hypothesis is a well-known pathway on how familial cancer occurs. In this, one part of your mutated gene is already acquired in your through your birth, and the next change happens over your growth or over your development. So the occurrence of tumor is very early when compared to the normal population, which is of your age. Okay, so coming to Mendelian inheritance, it is there are two types basically, which is autosomal dominant and autosomal recessive. In autosomal dominant, if you can see the affected person, there is only one mutated gene instead of two mutated genes. Even the one mutated gene is enough to cause a disease in your next generation. So about 50% of the next generation would be affected by the disease you are having. In autosomal recessive, there should be two copies of mutated gene. So 1 in 4 of your of the next generation will have the disease. So one has to be carried from the mother and one has to be carried from the father. So cancers discussed today are breast cancers, colorectal cancers, ovarian and endometrial cancers, stomach and thyroid cancers. So there is a role of preventive surgery in the hereditary cancers. So what is the role of surgery here? So here genes having high penetrance level, that is, if a gene is there, how much of the percentage of population having this gene will have a cancer. So if it is above 80 or 80 or above, we can say that it has a high penetrance level, and chance of you having the disease is also more. And in these surgeries, the morbidity or the complications associated with the surgeries are less when compared to a cancer patient, and even the mortality associated with the procedure. So it also decreases the chance of future malignancy at the cost of some nutritional and long-term side effects. So coming to hereditary breast cancer. So it is an important thing to talk. This is the Angelina Jolie effect, which started in 2013. So Angelina Jolie had a mutated BRCA1 gene, and through her since she had broken up barriers regarding her personal history, and she wanted to share these history to the outside world, she has benefited a lot of patients now. So her mother had died of breast cancer, and on genetic testing, she had an BRCA1 gene and had an 87% of chance of developing breast cancer and an ovarian cancer through a lifetime. So she had preventive mastectomies, bilateral mastectomies done and reconstruction in 2013. And since 2013, there has been increase in genetic testing for BRCA1, BRCA2. Not only not only the doctors have emphasized on it, even the patients on their own have emphasized on it. So this meant that more patients have been asking for BRCA1 and BRCA2 mutations, especially the young ones. So more, if tested positive, they have opted for a prophylactic mastectomies and to greatly reduce the risk. And this also meant that in some cases where a preventive mastectomy was not needed, patients still chose them to have it. So the percentage of women who opted for a bilateral mastectomy, preventive mastectomy rose from 5.4 to 30% in 2011, and it has been increasing since then. So there are some guidelines which are given to us when to suspect and offer genetic testing to a patient with breast cancer. So usually about 85 to 90% of breast cancer that run in family are usually due to BRCA1 and BRCA2. And the remaining 10 to 15% is contributed by this PALB2, CHEK2, and ATM mutations. There are a lot of syndromes, about 8 syndromes, which can contribute to breast cancers, but we are just going to touch upon the basic guidelines and stuff. So patients with early onset breast cancer, usually less than 50, you should offer a genetic counseling. After genetic counseling, we have to decide whether genetic testing has to be done or not. And a patient with triple negative breast cancer, which is a subtype of breast cancer, and who are less than 65 years old, have also need to be tested. And patient with personal history of a second breast cancer or ovarian cancer in herself, and unusual presentations like a male having a breast cancer, and patients with one or more first degree relatives with breast, ovarian, or a male breast cancer, multiple family members, not only first degree, including first and second degree relatives having cancers like breast, prostate, pancreatic, uterine, and other subset of cancers. And in patients with metastatic breast cancers, it offers some therapeutic benefits because we have targeted drugs against those mutated genes. So coming to the surgical options, there are two as of now. These are risk reducing mastectomy and risk reducing salpingo-oophorectomy. It means risk reducing mastectomy in removal of your both breasts with reconstruction, and risk reducing salpingo-oophorectomy is removal of both of your tubes and ovaries. So how much of a protection do those give? In bilateral prophylactic mastectomy, about 90 to 95% reduction in breast cancer is seen, and about 80 to 100% of reduction in breast cancer mortality associated with breast cancer if the patient is prevented from breast cancer is also seen. So the general advice which we give in such cases is to complete these surgeries as close to the completion of childbearing as possible. So even after these surgeries, there is a minimal risk, about 1 to 9%, to develop cancer in the residual tissue, because in surgeries we cannot remove 100% of your breast tissue. So about 4 to 5% of your breast tissue might remain. So there is a chance that cancers can happen there. So what is in risk reducing salpingo-oophorectomy, there is dual protection. One is protection against your ovarian cancer and protection against your breast cancer. So again, in BRCA1 and BRCA2, about 50% reduction in breast cancer is also there, only if you remove tubes or ovaries. So in BRCA1 and BRCA2 mutation, risk reducing salpingo-oophorectomy and mastectomies are always recommended. So we also saw that the greatest benefit was at about 40 years after completion of childbearing, and the combination of mastectomy and salpingo-oophorectomy both. So at or before 40 years, if you do these both surgeries, about 87% of benefit is seen. So this is the mean gain in life expectancy when you do both. So the benefit is maximum with mastectomy and oophorectomy. So as you can see, the benefit is more at 40 years with both the surgeries done, with about 77 and 82% in both mutations. So coming to colorectal cancers. So the first one I'll be discussing is familial adenocarcinoma.
Again, Dr. Rahul, how long is it? Because we are into last 5 minutes of the program and I need to take some questions also. So I want to know how long is your presentation?
I can complete in another 5 minutes, ma'am.
No, we are left with 5 minutes only,
Yeah.
an hour long.
So
just wind up.
So I'll just skim it. Okay. So in colorectal cancers, there are other associated cancers also. So depending on the guidelines and protocols which say, the age of starting colonoscopic surveillance in patients with these syndromes can be started at about 20 to 25 years. And if they are not willing for 20 to 25 years, at least 5 years before the earliest cancer patient in his family. And the other thing is these colorectal cancer also have preventive surgeries which are called total proctocolectomy or totocolectomy, removal of entire large intestine followed by reconstruction. So these have long-term nutritional side effects, but these are advised as soon as they complete their early teens or come into adulthood, so that their development is already done. So other cancer which spreads hereditarily is gastric cancer, and these also have criteria. So better to suspect a hereditary cancer if you have a first or second degree relative who is less than 50 years old, or if a person is having a stomach cancer of a specific subtype before the age of 50 years. So for these are the preventive surgeries on a whole offered to patients with cancers. Like for endometrium, we give a removal of uterus, and for a gastric cancer, we do a total gastrectomy done. So these last two to three slides are very important, so that general population, a general person, a normal person can detect or doubt this one. Young age or less than 50 years of breast, ovarian, colon, or stomach cancers, and several type of different cancers in the same person. Multiple primary tumors, especially in the same organ, such as breast or colorectal in a single individual, and relatives having similar cancer types and who were diagnosed at an earlier age, and unusual presentations like breast cancer in a man, and some specific skin lesions or skin growth associated with cancer can also be a high value point in which we can suspect hereditary syndromes. So the take-home points: we need not be famous or rich like Angelina Jolie to take informed decisions. You just have to meet an oncologist or a doctor for that sake, for giving you the whole picture. And also, if you're a cancer patient, always ask the doctor whether you should get a genetic testing and counseling done or not. and always ask about the risk of cancer in your family or yourself, or of being an hereditary cancer when you visit an oncologist if you are a cancer patient. Thank you.
Thank you, Dr. Rahul, and my apologies that we had to really cut short the
Yeah.
presentations. And some of the audience members have asked that if these slides could be circulated because they couldn't see the entire thing. I'll just quickly take maybe 3 questions. Dr. Alvin, maybe you could take this. Like, we have focused on specific cancers. So now Ramar Ramesh is asking whether there is any common screening for all types of cancers, or there are specific biomarkers for early diagnosis of cancer. Like, we are going organ wise, but is there any general specific test?
So currently, we don't have any general screening test as such to detect cancers, which is the common question we face in our clinic also. Most of the time, it is organ specific. But I would like to put forward that research is going on, that sometimes we may come in the future that there may be the molecular biomarkers may be available, that even before the cancers are detected, the cancer cells can be seen in the blood. So such research work is going on, but currently we don't have a general screening test as such.
Mm-hmm. And Dr. Sindhu, you spoke about the false positives and false negatives. So suppose a patient gets a false negative, and then, as you also recommended, there has to be a gap before we do the next round of tests. So somebody wants to know what happens if the false negative is actually kind of brewing up the cancer in the body and it is going undiagnosed. It's remaining undiagnosed.
Yes, well, that is a drawback of a screening tool. There can always be a false negative, and it is really difficult to diagnose such a patient because they're asymptomatic at that point. We are doing all these tests on asymptomatic individuals. So there's really not much we can do if there is a false negative with the screening tool. So that is one drawback with these screening tests which are available. But the percentage of having a false negatives with the mentioned recommendations is very less, so that gives us a hope towards diagnosing it at an early stage.
Dr. Alvin, you also mentioned about the dietary habits. So you talked about specific foods which perhaps lead to cancer. What about the food? What about malnutrition? Does
Yes,
that also lead to
malnutrition
cancer?
is also very important because it contributes to less immunity in the body. So, apart from the unhealthy diet, one has to be very careful on addressing the malnutrition, taking a proper proportion of a balanced diet, which contains proteins, carbohydrates, and vitamins that are very important because if they fall short, we know that the free radicals and the oxidative stress that happens in our body can predispose to cancer. So malnutrition is also very important. But as such, we don't have a research saying that malnutrition predisposes to this particular cancer because it is interlinked. Malnutrition can predispose to any type of cancer because it can affect the immunity.
Dr. Rahul, maybe you could answer, like, if somebody is having continuous infection of the stomach or intestine or pancreas, whatever. So, is it also an indication that it could lead to cancer in the long run?
Yeah, in stomach it is proven, ma'am. Already there are infections which are shown to develop into a stomach cancer. Like there is an organism called H. pylori, which is usually present in about 50% of the general population, even including me or you. I don't. But the general having that infection doesn't mean that you will get a cancer. It has to go into other processes like change in their behavior. So that happens very rarely. So it has to go into a chronic state of infection or inflammation, causing more changes to the gastric wall, which causes cancer. So in such cases, if patients are nowadays with endoscopic, and we have endoscopic surveillance for such patients who are symptomatic, who get tested for H. pylori and treated for H. pylori also, so that the potential to change into a cancer is reduced markedly. So even in colon, some organisms are postulated, but there is no definitive proof, but if there is an inflammation, long-standing inflammation along with an infection, there is always a possibility of it developing into a cancer. So if you're having change of bowel habits or change in any if you're having loose stools and constipations alternatively, so it's better to get evaluated with a doctor, get evaluated properly, so that we can come to early diagnosis.
We spoke, of course, focused on preventable, how cancer could be prevented, but could one of you quickly tell which are the curable cancers? Well, that is also a question, like which are the non-curable cancers and which are the curable cancers?
Yeah,
There
so
is no such.
yeah,
So
go ahead, go ahead.
I mean, all cancers at an early stage is curable, and only there are cancers at advanced stage we speak about incurability and just prolonging the life and giving a palliative care. So any cancer which is diagnosed at an early stage, the great hope is it is curable. And there are some cancers like lymphomas, even at advanced stage, there is a high hope that it can still attain a cure. So it is the stage of the disease that matters, not the type of tumor.
Mhm. And do you think because cancer is generally considered an expensive treatment and there's a lot of fear and anxiety involved with it, so that is why people also don't come for testing or screening? Could that also be a reason for higher incidence of people living with cancer?
It could be one of the reason. The major reason is the fear of the enigma of cancer and the fear of treatment that they assume in their mind. For example, for a surgery or for chemotherapy or for oral tablet treatment, the fear that is there in the common public is it may cause some pain in their body. The treatment may induce pain. It is going to be a long-standing one, and it can cause loss of hair and skin changes, so they won't be able to move out into the public space. So that is the major fear, and the fear of death. So even an early stage cancer patient or the individual tend to neglect for a long period of time until it get advanced, because the fear into them is once they get exposed to the doctor, he will plan for some investigations and treatment that is going to take time, and the treatment is going to be some sort of pain involved treatment, which is completely not true. And these are all false anxious, which has to be avoided. We recommend all the patients to come forward if they are diagnosed with cancer, come forward and plan for an early treatment so that it can be cured if it is diagnosed at an early stage.
So any one of you could, maybe this is the last question. Why do you think that our awareness campaigns have not been able to penetrate the masses with the important message? And somebody has put out a very long question asking about what are your considered recommendations to reduce tobacco in public life, for instance. So the focus is awareness, why and where have we failed?
Awareness is always important, ma'am. I think there should be more ads and stuff telling about tobacco, not only the cancer part, and there are other aspects to negative aspects for tobacco, which can cause you increased risk of heart attack or stroke. These things also have to be emphasized, and I feel legislation is also very important. Legislation and de-addiction, these are all very important along with awareness, because once you're aware, it is not only being aware, you have to stop and you have to have a dedicated program for de-addictions. And legislation for stop only increasing the price of cigarette or a smoke won't can reduce, but it will not impact health on a larger scale of population.
Right. And I'm really sorry that I had to rush you through the questions and the session because of lack of time. Maybe you could take the questions separately. There are a few more, and also circulate the slides because there is a lot of requests for the entire presentation. And with this, we'll close today's webinar on cancer early detection and prevention, which was presented by the Hindu Wellness Series in collaboration with Naruvi Hospitals, Vellore. Thank you very much.
Oh, thank you.